Okay, great. Thank you, everybody. Thank you, everybody, for calling in. And as Martine said, good morning, good afternoon, good evening to everybody here. Dr. Sattar and I are really excited to pull together a talk. It was a great idea and a whole lot of fun. We were reminiscing last night about this. We were able to do this in Geneva in 2019, where we were able to have it at the conference, at the SIOG conference. We had a huge group of people go through, and we think we had the best part of the whole show, able to really truly demonstrate bits and pieces of the geriatric assessment. And one of the parts that we had was the physical performance measures. Glad that we could meet today via Zoom. I would have preferred in person and testing all of the gait speed of everybody on the call today, but this is the best next step, I guess. So thank you all for joining, and we appreciate your interest and for joining us today. So we'd like to first start with a case study, just to bring it back to the patients that we care about. 73-year-old patient with metastatic prostate cancer was in clinic for follow-up. So we tried to picture what we've both seen clinically and how this could relate, and we'll talk about this patient throughout the case. So 73-year-old male, prostate cancer, was on Lupron, has been receiving it for the last 8 months, lives with his wife and a dog in a one-story home. As per routine protocol, his gait speed was administered and measured by the clinic nurse. We also looked at his hand grip strength. His test results showed that his gait speed at this time was 0.6 meters per second, and hand grip was 30 kilograms. So the patient reported that he was able to walk a block every morning previously, but most recently, he's not been able to do so due to fatigue, and he just wasn't feeling up to it. So back to the background and the research. Why are physical performance measures important, and why is it important in particular for older adults with cancer? Well, we know that so far, that cancer and cancer treatment can truly directly and indirectly affect older patients' gait and balance through a number of different ways, through levels of fatigue, through different types of, through chemo-induced peripheral neuropathy, and others. And we also know that typically how performance status is measured through the Karnofsky or the ECOG are not sensitive enough to pick up how patients are truly performing in their day-to-day. We also have learned that for sarcopenia, when we're thinking of reduced muscle mass, can be common in older adults, and in some cases can be as high as 57% of the older adult cancer population. But we need a way within the clinic that's fast and easy to do, that we can capture this decline and potential impairment, looking at specifics to muscle strength, speed of movement, coordination, flexibility, and balance. Because for older adults with cancer in particular, these physical performance measures are related to and associated with survival and treatment-related complications, functional decline, and falls. But it can also add to our prognostication for survival and informed treatment decisions, as in chemotherapy treatments, et cetera. And it can inform care planning and trigger appropriate interventions, follow-up, and referral. So anything from exercise programming to cancer rehabilitation specialization. So when we think about evaluating someone's physical performance, we wanted to pick a couple of our favorite measures, and we'll discuss why we chose these measures, that were quick to administer, that required minimal to no special equipment or training, that could be easily included during patient encounters in oncology clinics or in rehab clinics. The tests that we recommend are gait speed, timed up and go, the chair stand, balance test, and the short physical performance battery. And during this talk, we'll be going through each one of those in a little bit more detail, the how-to behind them and some of the research behind them, and showing you a couple of videos of what they look like. Oh, and the one here, I'm sorry, is hand grip. Just realized that's not missing, but we will talk about it today. So gait speed. Gait speed has been talked of as the functional vital sign, or the sixth vital sign. It's to real. I think gait speed and I would argue probably hand grip are two of the probably the most critical measures of physical performance that can really give you a sense of what's going on overall and give you a sense of a measure of frailty, because they're really strong predictors, and gait speed in particular is a strong predictor of mortality, treatment-related complications, healthcare utilization, and functional decline. Gait speed takes about less than 5 minutes to administer, depending, of course, on someone's speed. Resources are required: measuring tape, masking tape, or duct tape. Or typically, I try to use something that's really bright and easy to recognize, depending on the color of your floor. At a very minimum, you need 4 meters. Ideally, you want at least 14 meters or a little bit longer, and a stopwatch. So this is a great figure that kind of gives you a sense of what it would look like for gait speed, but I'm gonna click on this and we can watch a video to look at what it actually looks like. Fingers crossed here. Yes, in the meantime, while this is loading, I'm just taking a moment to look at the chat. There are recommended assessment tools that you can use for telehealth. I think that's a great question. So one of the ones that we've been using in telehealth here is we use gait speed and have them measure it out. A lot of times we use the timed up and go. It depends on the how safe, like the safety, like how safe you feel for the patient to be able to do that over the computer, and also if they have a companion at home that can help out. And then my last, and we can talk about some suggestions once we get to grip strength of how we've been trying to figure out ways, fun and engaging ways to do that at home. And the 5 stands, yes, 5 sit to stand chair test, and we also use the 30-second sit to stand chair test at home as well for telerehab. Okay. So this is, let me know if you guys can hear it. I don't. Are you guys hearing the video at all? No, I can't hear it either. Hold on 1 second. I have a feeling it's my headset. Oops, apologies, 1 second. How about now? No? 1 second. Yeah. Good.
Assistive device to perform the test and must wear shoes. It is
Okay. Here we go.
Flying
Thank you for
start,
waiting.
meaning that the patient walks a distance of 14 meters, but the time is measured for the intermediate 10 meters. The individual walks at their preferred walking speed. They can use an assistive device to perform the test and must wear shoes. It is recommended that the test administrators mark the floor at 0 meters, 2 meters, 12 meters, and 14 meters to facilitate the timing. Equipment required. The equipment required to perform.
Okay, glad we could get that working. Can you still hear me without the headphones? We still good?
Yeah.
Yeah, okay, great. Okay, so specific cutoffs for gait speed. So gait speed, a cutoff, if you're looking at for increased risk of frailty, is 0.8 meters per second. And this here is the 10 meters divided by the seconds will give you your meters. Okay, another measure of functional mobility and physical status would be your timed up and go test. So this is a great test of functional ability and change over time. One of the things I like the timed up and go for is the scoring is helpful and the cutoffs are helpful, but it's also, I think, from an occupational therapy perspective, it's a great way to look at quality of movement because you're asking someone to go from a sit to a stand, walk and turn around and come back and sit back down. So you can really see how they're moving around objects and how and their ability and quality of movement around those objects. So the timed up and go is significantly and independently associated with future falls. In cancer in particular, it's related to frailty, fall risk, of course, inflammatory markers, levels of fatigue, pain, burden from other comorbid conditions, and even potential early death risk. So it's a pretty sensitive test for something quite general. Takes less than 5 minutes, could be quite quick to administer once you have the setup. Just requires a chair, again, the tape, distance of 10 meters and a stopwatch. So when you administer the tug, you have the person stand up from a sitting position, walk forward, turn around, return to the chair and sit back down again, wearing their normal footwear, walk at a normal speed. So sometimes you will see patients like stand up and try to run around the cone. You don't want that, just at your normal walking speed. They can use any assistive device. And there's no necessarily time limit to them, but there are cutoffs. So let's watch this quick video here. Okay. So the cutoffs for this, try this one more time. The cutoffs for the timed up and go are anything greater than 9 to 10 seconds has been recommended for a cutoff for the timed up and go. Sometimes anywhere in the literature you see a debate between all the way up to 20 seconds, all the way down to 8 seconds. For patients with cancer, we typically look more around the 9 to 10 seconds as a predictor of potential risk for falling. So before I switch, let me see if I can, excuse me, I'm sorry, try to pull up the video one more time. But in the meantime, Dr. Sattar, do you want to take over while I try to pull up the video?
Sure. So would you like me to start the chairs then, or shall we wait a couple of seconds for the video?
I think if you'd like to go ahead and start the chair stand, and then I can pull up the video on the side and get that pulled up and we can do both. Thank you.
Okay, sounds good. Yeah, so the next thing we're going to look at is the chair stand test. So as we know, age-related decline in the lower body strength is linked to deterioration of functional performance, and measuring of lower body strength is quite critical in our efforts to evaluate functional performance in older adults and older cancer patients. So the chair stand test is a pretty useful tool in this regard, and it basically involves moving from a seated to a standing position. And such maneuver would require the lower body strength, and it has been used as an indicator of lower body muscle function. And we know that from research, it not just indicates lower body muscle function, but also the patient's balance, functional mobility, and it's been pretty useful in terms of predicting falls, physical health status, and any functional decline and frailty in older adults.
Dr. Sattar, are you still there? I think you're on mute.
Yes,
Oh.
I'm just thinking the same thing.
For some reason, my
Okay,
mouse drifted.
sorry.
My apologies. When was I cut off? Maybe I should start the slide because I wasn't sure.
Yes.
Okay, so typically one approach to do this is to measure the time it takes the patient to perform a given number of sit-stand sets. Typically is 5 times or 10 times. 5 times is more common. So you're going to time the person and see how long it takes the patient to complete 5 sets of sit-stand. And another way is to impose a time limit, so 30 seconds, and see how many sets of complete sit-stand the patient can complete within the given time. And it's also a really easy and quick to administer test. And on average, it takes less than 3 minutes to complete. And you only need a standard chair, which is standard, typically between 18 to 19 inches in height, and a stopwatch or smartphone timer. Okay.
It looks like it mutes you every time we change slides.
Yeah,
Yes.
it is bizarre. Okay, I'll keep an eye on the mute thing. Okay, so in terms of how to administer the 30-second sit-to-stand test, so basically the most important thing to keep in mind is the patient's hands have to be on the shoulders, on like the right hand on the left shoulder and the left hand on the right shoulder, so crossed at the wrist in front of the chest, and their feet have to be planted flat on the floor. And posture is really important in terms of completing the sit to stand. You have to be, the back have to be straight. And so you're gonna ask the patient to, okay, you have 30 seconds, please try to complete as many sit to stand maneuver as possible. And typically we demonstrate for the patient first before we ask them to execute that movement. So there's a video, and let's
The timed up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move. and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. The 30-second chair stand tests functional lower body strength. To administer this test, you'll need a chair with a straight back and a stopwatch. Place the rear legs of the chair against a wall so that it cannot slide backwards. Have your patient sit towards the front of the chair and fold her arms across her chest. Ask her to keep her feet flat on the floor and sit upright. She should try to stand up, keeping her arms folded across her chest without pushing off with her arms. When you say go, she should stand up all the way and then sit back down, doing this as quickly as she can until you say stop. Arms should remain folded across her chest throughout the test. Stand close enough so that you can catch the patient if she loses her balance. If the patient gets tired, she may rest, but let the time keep going. If she cannot stand even once, the test score is 0. Not being able to stand up from a chair without using one's arms to push up indicates a high risk for falls. Record the number of times the patient stood up in 30 seconds. If the patient is over halfway to a standing position at the end of 30 seconds, count it as a stand. Now, based on the age and sex of your patient, find their normal range on this chart.
Okay, so this is the cutoff scores for the 30 seconds to stand test. So as you can see, it's based on sex and age. And for our particular patient, Mr. B, so he's 73 years old. So he would be in the 70 to 74 category. And according to the cutoff, anything below 12 would be abnormal or below normal in this test. So the next test we're going to look at is the short physical performance battery, or the SPPB. And this test is basically a combined group of performance tests, and it's really useful for predicting disability, functional decline, and hospital admission, institutionalization, and also mortality, and not just older adults, but also older adults with cancer. And as you can see here is actually the gait speed and balance test and chair stands added together. So all these components. So we would like to show you a video on the balance test and see how it works.
The purpose of this video is to teach you about the short physical battery test, or SPPB. The SPPB is a validated tool that we can use to assess a patient's level of physical function as well as their future risk for activities of daily living decline. It is a performance-based test and it will take about 10 minutes to administer. Okay, let's begin the evaluation. I'm going to have you standing in a couple different positions, and first I will explain them and show them to you with my feet, and then after you see me doing it, you can get into the position, and Ken here will time you, and we're going to try to hold these positions for 10 seconds each. Anytime that you feel unsafe, just let me know and we'll move on to the next section. Anytime you need to step out of the posture to maintain your balance, we will have to move on to the next section.
Okay.
So when you are standing in the posture, you can move
your body and your arms and bend your knees in order to maintain your balance. The main thing is we want your feet to stay in place for the 10 seconds.
Okay.
Okay, so let me show you the first position that I want you to stand in. And just watch me for a second as I show you. We want your feet next to each other and touching for 10 seconds, okay?
Okay.
Do you have any
Okay.
questions before we begin?
No.
Okay, so let's have you put your feet into this position here. Great.
Okay, are you ready?
I'm ready.
All right, begin. And stop.
Great, and you can just stand normally. Let's look at the scoring for the balance section. The side-by-side stand is worth 1 point if the patient can successfully hold the position for 10 seconds. So the second position is having your heel of one foot around the toe area of the second foot, and we'll have you choose whichever foot you feel more comfortable with for the front and back, so you can do either side. You're going to hold this position for 10 seconds again, and you can move your body, your arms, and bend your knees if you need to maintain your balance. Just try to keep your feet in this position.
Okay.
Do you have any questions about that posture?
No.
Okay, so let's have you get into that position there. Great, and let's have you move that front foot back about 2 inches. Perfect, thank you.
Okay, ready and begin. And stop.
Great, and you can stand normally. The semi-tandem stand is also worth 1 point if the patient can successfully hold the position for 10 seconds. And I'll show you the third posture. The third posture is putting the heel of one foot against the toes of the other foot. And once again, you can choose whichever foot you want in the front and in the back.
Okay.
Okay, and you're going to hold this for 10 seconds if possible. And once again, you can use your arms, your knees, and your body to maintain balance, but try to keep the feet in that position. Do you feel that would be safe?
I think so.
Okay, do you have any questions about this one?
No, I
Okay,
don't
let's
think so.
have you try to get into that
Okay.
position. Good.
Okay, ready, begin. And stop.
Good. Okay, thank you. The tandem stand is worth 2 points. If the patient can successfully hold this position for 10 seconds, they receive the total 2 points. If they can only hold this position for 3 to 9.99 seconds, they receive 1 point. If they cannot hold this position for 3 seconds or more, or they cannot attempt it, they receive 0 points. Since our patient successfully held each of the 3 postures for 10 seconds, he received the full 4 points for this section. Now I'm going to observe how you normally walk. This is our walking course here. Walk at your normal speed as if you're going down the street to the grocery store, and to walk towards the end of the course and past the line without slowing down.
Okay.
And I'll walk right with you and make sure that you feel safe, okay? Can I show you what I mean?
Sure.
Okay. When you're ready, I'll say ready, begin, and we'll have someone timing you when you cross the line. You'll need a timer that goes to the hundredths mark and the walking course marked in advance. If the patient uses an assistive device and needs it for short distances, they can use it.
Okay.
Okay, so can I have you line your feet up behind that line right there? And are you ready?
I'm ready.
Good. Okay, ready? Begin. Start timing when the patient begins walking across the line. Stop timing when one of the patient's feet is completely across the line. And we'll do this again.
All right.
So now I want you to repeat the walk, and just remember not to slow down as you reach the line, but rather to walk past it. And I'll have you line up, and if you're ready.
I'm ready.
Okay, ready? Begin. Since our patient's faster 4-meter walk was 3.5 seconds, He received the full 4 points for this section. Use your SPPB guide for proper scoring. Okay, let's start with the final portion of our assessment. Do you think it would be safe to stand up from this chair without using your arms?
Mm-hmm.
Okay. Let's have you cross your arms over your chest like this. And can I have you put your feet flat on the floor in front of you? Great, thank you. And go ahead and try to stand up without using your arms. Great. Okay, let's sit back down. Stop the test if the patient uses their arms to stand, has not completed 5 rises by 1 minute, or at your discretion if you are concerned for patient safety. And now we're going to have you do that 5 times in a row as quickly as you can, okay?
Okay.
Do you think that would be safe?
I think so.
Okay. And just remember, if you feel dizzy or short of breath or you don't feel well in any way, let me know and we'll stop, okay?
Okay.
Great.
All right.
So let's put your arms over your chest and make sure you keep them in that position during your 5 stands, okay?
All right.
Great.
And I'll be timing you. Are you ready?
Oh, I'm ready.
Okay, and begin.
1, 2, 3, 4, 5. Great, thank you. Since our patient's time was 14.96 seconds, he received 2 points for this section. Use your SPPB guide for the proper scoring. The SPPB score can help you understand the patient's current physical status as well as their relative risk for ADL decline over the next 4 years. Add up the points for the 3 sections of the SPPB to get the total score. Our patient's final score is 10 out of 12 points, which corresponds with minimal limitations in physical function.
The only thing I would add is you might, by watching that video, I would suggest putting the chair and the 5 times sit to stand against the wall and not in the middle of the room. That would be
Exactly.
the only. Yes. Okay.
Yes. That would be a concern for safety. So we want to make sure that the chair doesn't move, even if it's in the video, even though it seems to be against a relatively heavy object, but you never know. Things do get moved sometimes. So as Dr. Pergolotti say, the safest thing would be by the wall in that regard. And that. And I will unmute myself since it is a new slide. So as suggested in the video, the patient score was 10. According to the video, so between 10 and 12, that's a relatively high performance according to the scale. But in some literature, it's also recommended that anything that is not lower than 10, but also sort of like at 10, because it's considered a more borderline score that could potentially indicate possibility of impaired mobility as well. So it might not necessarily mean that the patient is at risk for any negative events like falls or other things, but it is good to keep an eye if the patient score is 10, because it's sort of at the border. And then the next thing we're going to look at is the hand grip strength test. The hand grip strength test measures the maximum isometric strength of the hand and forearm muscles to provide sort of like a general measurement of arm strength. And as we all know, hand grip strength is important for a variety of daily activities and also recreational activities. It has been shown to be linked to increased risk for functional impaired function, mobility limitation, and also survival, quality of life, and fatigue in patients with cancer. And this is also a relatively easy to administer task. On average, it takes less than 5 minutes to complete. So, and just a note that once when we administer the grip strength, once the grip position is adjusted in a person's hand, and we will have the patient hold it and basically let them know that you're going to squeeze it as hard as you can. And if we are using a hydraulic dynamometer, as we know, there are different versions of the dynamometer to use to measure the grip strength. An older, a traditional one that we typically see in our clinical practices is the hydraulic dynamometer. And nowadays, there's also a digital version as well. If you're going to be using the hydraulic version, just know that the red needle would stay at the highest reading level unless you reset it. Okay. And for the digital version, it will just display the results directly. And the dynamometer is a really useful tool in testing the person's upper limb muscle strength. So in terms of how to go about doing it, the first thing we need to do is have the patient remove any watches or bracelets or anything that might get in the way. And also we can record the patient's hand, dominant hand, which one is it left hand or right hand? You can ask them directly, or you can just observe by watching, which usually people will have their watches on a non-dominant hand, and they will remove the watch with a dominant hand. But also it's good to confirm with the patient. It doesn't harm. And the first thing we want to do is to demonstrate to the patient how to hold a dynamometer and explain to them that you want to squeeze the machine as tight or as hard as possible. And to be sure that for this particular test, again, posture is really important. Make sure they're seated comfortably in a chair with a good back support. And in terms of their upper body, the shoulder should be really close to the side. The upper arm should be really close to the side with the elbow flexed at 90 degrees. And ideally, we want to use a chair with arms, not for the forearm to rest on, but sort of give us sort of like a relative measure to eyeball to make sure that their forearm is parallel to that chair arm, just so that we maintain that 90 degree of flexion for their elbow. Then we want to instruct also the patient not to let their feet go up or move from the floor while they're squeezing the machine. So technically, there should be no body movement while they're squeezing the dynamometer. Okay. And keep in mind that if we're using a handheld a hydraulic dynamometer, the red needle needs to be set to 0. So we're going to start by encouraging the patient to squeeze as long and as hard as possible until the needle stops rising. So typically, it takes about 3 to 5 seconds to do so. And usually we follow a standard phrase. We can say, okay, start, squeeze, harder, and stop squeezing. Something like that. And then we're going to check the dynamometer, look at where the red needle is, and record the result to the nearest kilogram. And after the test on one hand is done, we want to repeat the test on the other hand, and be sure to allow the patient to rest after one set is done, meaning say for instance, the left hand first and the right hand after that, because we want to do 3 sets ideally. So make sure we let the patient to rest about 15 seconds between the sets, and then we'll record all 3 measurements. In terms of okay, we're going to move on to the next slide. Just wanted to. Okay, and in terms of scoring, so this is what it looks like, and it is common practice to use the highest reading of the dominant hand. However, in some protocols, it is also recommended to average everything from all 3 sets to get an overall grip strength of the dominant hand. Okay, so going back to our patient, Mr. B, his gait speed was 0.6 meters per second, and his hand grip was 30 kilometers. Oops. So based on the patient's gait speed, he was considered at risk for falls, and also his hand grip strength was below the limits for based on his sex and his age. So the nurse who administered the test and collected the information communicated the findings to the patient's treating physicians. After discussions, they decided to make the following referral for the patient. One of them is referral to the geriatric team for doing a comprehensive geriatric assessment and also further follow-up. And also referral to occupational therapists for home safety evaluation. And it's going to be done on telehealth rehabilitation because the patient seems to be at risk for falls and may have other frailty issue as well. So safety is important. And another referral is to the physical therapist for exercise program and specifically resistance and strength training program to strengthen the muscle and in regard to their fall risk and potential issues with balance and mobility as well. I just wanted to talk about some of the special considerations when performing or when administering the physical performance measure test. Okay, research suggests that tests that are done in the patient's familiar environments, such as their home or places where they live, may be more relevant. And it's because it is in these places that the patient is usually carry out their daily functioning. So it may be the most relevant. So administering the test in a patient's home, say for instance, somebody asked about doing that on sort of like a remote basis, telehealth, the format is actually quite beneficial in this regard. And also, as mentioned in the video, prior to start of the test, we want to assess safety and suitability of the patient to perform the test. And if you feel that the patient may be too weak or look unsteady, do not perform the test. And also, whenever possible, stay within an arm's length while administering any gait, balance, and mobility tests. Obviously, in the event the patient may lose balance and they may fall and injure themselves. And if we're conducting a remote testing, ideally, we want the patient to carry out the test while they are accompanied by someone, say, for instance, a family member, a caregiver, or maybe some patients may have a friend or a neighbor who can help, again, just for safety monitoring and staying within an arm's length of the person in case they lose balance. And in the case of a balance test, for instance, which doesn't involve the patient walking back and forth, it might be sufficient if the patient stays close to hold on to the kitchen counter or a table or a sturdy piece of furniture, or ideally by the wall, so that they have something to hold on to if need. And keep in mind that it's important to stop the test immediately, as mentioned in the video as well, if they cannot execute the maneuvers or if you feel that safety may be an immediate concern at the time. And also during the grip strength test, when we're doing the grip strength, if you notice that if the patient's arm rises sort of above the parallel level where they're losing that 90-degree flexion, or if their feet start to shuffle around or move above the floor, we'll have to disregard that recording and start over again. So on that note, we'd like to thank you for your time, and we welcome any questions that you may have.
I see a few questions on the chat I'd like to address before we open it up. The first question is about using your arms in the timed up and go. So the patients, it's not recommended for them to use their arms, but of course they can if they need to. And what I would say is make that as a note in your chart, because you're going to want to know that they needed their arms in order to go from a sit to a stand. And that goes back to the quality of sit to stand. And then the other question that we got was the, if I had to choose a timed up and go or the 2-minute walk, I think it depends. I hate to say it depends, but it kind of depends. I would start with the timed up and go. That's going to give you some information that the 2-minute walk may not, but it depends on exactly what you're looking for in terms of functional capacity when it comes to gait speed, and also quality. The one other question I wanted to answer was for hand grip strength. When we're doing that at home, in telehealth, one of the things that we've been using, I would say, is not the most. It's never going to be as good as a dynamometer, of course, but not knowing that not everybody has one of those at home in their closet. We've been asking patients to use either a bathroom scale, so like squeezing onto a bathroom scale with one hand, which has been, if you use that consistently, at least they're using the same measure. The other thing we've been doing is just doing a functional assessment. So asking patients to demonstrate how they would lift like a gallon or a half a gallon of milk, asking them about how they're lifting and using pots and laundry baskets. So like large things, small things, and the ways that they're moving in that way.
Yeah, and in exercise context, we use soup cans.
Soup cans, yeah. Soup cans are better than jars. Yes, agreed. Any other questions? I'm trying to see if I'm going to read through the chat here.
There's one more question on the chat, Mackenzi.
How can you reconcile testing patients via telehealth if they live alone? Yeah, that's a great question. And especially in a pandemic, sometimes you can't ask your neighbor to come on over. So it depends on what you're looking for and the patient themselves. If they're living at home, they are mobilizing within their house. So you want to make sure that you can see exactly how they're doing that. I would, similar to what Schroder said, I would recommend doing some assessment when their chair is up against the wall where they can hold on to something if they need to. And then I would mark it that way in particular and make sure that I noted that. What interventions do you include?
Yeah, and sorry, I just wanted to
add
add
go
that,
ahead.
Say, for instance, for patients who live alone, oftentimes in clinic, we see that patients who don't live with anyone or maybe their families are far away in another city, sometimes they do come to the appointment with a good friend or maybe a neighbor. So that person, if they, obviously within the context of the pandemic, we want to keep people safe, but in the event that if, say for instance, their buddy or their neighbor is sort of like in a bubble with the person and they're already interacting on a regular basis anyway. So maybe, and we do know that because our assessment appointments is usually scheduled in advance. So maybe we can let the patient know upfront if you have a friend whom you think that is safe, or maybe who is already in your current bubble. So maybe you can have them come over and just to be with you during the test for the sake of safety. But then again, it really depends on an individual basis.
And I see one last question. What interventions do you include when deficiencies are identified? Good question. I think, I'll answer this from my perspective, from a rehab perspective. One of the things that we teach clinicians is two-pronged, I guess. The first approach is trying to maintain strength and balance as best as we can throughout. So we want to make sure that if patients are robust and able to do well on all their physical performance measures, we want to keep them there. So we can do, we recommend a lot of home exercise programs, aerobic and resistive programs and exercise programs to maintain their status. If they're starting to decline, then we're going to recommend whatever, interventions they may need, either physical therapy or occupational therapy and in both of those approaches, I would say to both adapt to in the meantime, based on making sure that we can get the activities and things they want to do in a safe way, and then also build muscle strength and balance ability and awareness of ability as they're going through their treatment and after. Any other questions, comments?
I have a question if no one is asking. This is a more practical question for myself. What is the advantage of doing the 30 seconds chair stand over the 5 chair stands if we do it as part of the SPPB, but what additional value would the 30 seconds chair stand give you?
So the 30-second chair stand will give you a little bit a better clue into their endurance. So their lower body strength and endurance. And one of the things I love the 30-second sit to stand for is like you can see how their posture changes. So 5 sit to stands are one thing, but 30 seconds can be quite can be much more difficult. And so you can see how their posture changes when they tire and fatigue. And also, which tells me a lot about what they look like probably at night when they're tired. And then the other thing I've used it for is, for me, it's been a great way for patients to see, like, to level set where they are functionally and capacity wise. So I've had patients who have said, you know, I feel really good. I don't think I've slowed down any, and I'll have them do the 30-second sit to stand, and they'll say, you know what, maybe I could use a little exercise program to feel a little bit better. So I've used it for that reason also. I don't know, Schroder, if you want to add anything to that.
Yeah, I agree. Those are really good points, and they're really important. Just one thing I wanted to add as well is it is argued that the 5-time chair stand it might have something that is called a floor effect. So because we're just telling the patient, please do 5 sets, and I'll stand here and time you and see how long it takes. And in the event if we encounter a patient who may be a bit on the more weaker or frail side, they might not be able to carry out even 1 set. So it's going to be pretty difficult for the patient. And you're sitting there with a stopwatch waiting, and for the patient, it most likely will make them feel bad as well, as opposed to, so how long do we take? Is there a deadline? So I'm going to give them 1 minute, 2 minutes, 3 minutes. Some videos do say 1 minute, but there's no definite time in terms of how long we're going to wait for them to carry out the first set, as opposed to the 30-second chair stand. We communicate the sort of like the timeline or the deadline up front, and just see how many they can carry out. So in that way, it's not just from the logistical perspective, but also I find it doesn't make the patient feel bad in the event that they can't carry out the 5 times, maybe just even 1 set of chair stand, instead of just having us standing there with a stopwatch staring at them, just in that sense.
Thank you. There is one more question online. Are these tests only for older adults? Are there any, what do you recommend for patients that are high risk for accelerated aging, and how often should they be measured?
Yeah, that's a great idea. Great question. No. In short, my answer is they're not just for older adults. I feel like, especially in the case of accelerated aging, I would recommend using it for all ages, even adolescents and young adults who were treated as children. I think there's been some pretty solid evidence that they have really intense levels of accelerated aging into their 30s and 40s. So making sure that you're doing assessments of physical function of all ages, I would highly recommend that. Schroder, did you want to add?
No, I think it is really comprehensive that you have captured.
Mm-hmm. Yeah. And then how often they should be measured depending on where they are in their cancer care continuum. So I would recommend a baseline measure, of course, if possible, and then depending on the types of treatment the ideal setting would be before, during, and after treatment. And then depending on the type of treatment, if there's a known late and long-lasting effects, then I would measure on screen the same time that you would be screened for future screening throughout your cancer care.
And and obviously I am always biased, so ideally I would recommend in terms of tests such as the gait speed or the tug, and every clinic encounter would be a good time to assess. And like Dr. Pergolotti described earlier in terms of the gait and the tug, and that can be done in back hallways, and it can be incorporated during the clinic routine, so it's not extra work on the clinic nurses. And it is important to administer all these, in particular the gait and balance and mobility tests, more frequently, because sometimes patients, their functional performance or and their mobility can change very dramatically even between the first and second cycle of chemo. So so that, and also for certain patients, for instance, the prostate cancer patients, if they are receiving androgen deprivation therapy, they can experience quite serious muscle loss. So it's also good to keep an eye on their muscle strength and also gait and balance as well.
And I would add, you know, I think these assessments are just as important as a patient-reported outcome measure of how they're perceiving their ability to function at home. I think they're just as equally important to figure to truly understand someone's functional age. So a combination of these and the patient-reported. And then one other thing that I would recommend using is the rate of perceived exertion. So when they're doing the the 5 times sit to stand or the 30-second sit to stand, getting a assessment of their rate of perceived exertion, I think will give you a really good, is also a very good indicator of how they're functioning.
Thank you. We'd like to thank our speakers today, and I just want to acknowledge, I think we introduced Dr. Pergolotti, but we did not introduce Dr. Schroder Sattar because she kind of came in halfway through. So if you're looking for Schroder, she's an assistant professor in nursing at the University of Saskatchewan. And I think, I'm not sure if the emails will be available for the presenters, but this presentation is recorded and will be posted on the SIOG website, and we'll tweet the recording link once it's available so you can share that with your colleagues. So once again, we'd like to thank everyone for presenting, and please feel free to connect with our presenters offline. Thank you all.
Thank you, everybody. Appreciate your time.